Hello and welcome to another Piper Pod. Today we're going to continue along with pharmacology and we're going to look at analgesia. So hopefully this would be a nice short one. Analgesia is something that we use quite often. So we're just going to go through a little bit on pain, looking at non-opioid pain relief and then looking at opioid pain reliefs as well. So before we start, we'll just have a look at what pain is itself. Now, as I promised, we're not going to go into too much details, but it's important to note that pain can be focused on from a purely linear science point of view, where you have the stimulus at the base and then the receptors found in the nociceptors in the peripheral ends of your nerves pick it up, and they can pick up whether it's direct pressure, release of certain chemicals, edema, vasodilation, whatever it is, they can pick this up and they transmit that to the spinal cord that sends it to the brain. And then when it's in the brain, it gets analysed by a number of different areas after initially going to the thalamus, being passed on to the limbic region, your primary sensory cortex, and your cortical associated area as well. So all three of those areas are involved. Now, because all those three areas are involved is where we get that subjectivity of pain, because pain is based on our interpretation and our analysis of that particular stimulus. Now, it's got a lot to do with how much experience we have with pain, how we as a culture or even an individual feels pain, whether you're in an environment where you're going to get the emotional response associated with not, if you're in a survival instinct, what your perceptions are on the actual consequences of this pain, and then all the way deep down to your actual beliefs and your logic and your ability to process information. And all of these particular things are put into account mostly in the limbic system and the cortical association area, and an output is felt. And the magnitude of that output is often determined by picture associated to the right has more of an input on pain than on the left. Okay, your actual primary sensory cortex is going to tell you where the pain is and how great it is, and how long that pain sits around and how it affects you has a lot to do with all the things that are written on the right. And that is why we often say pain itself is very subjective, because it is. Now, when we're looking at pain relief, we have two main different types. So we have the non-opioid ones and then the opioid ones. And they are involved in blocking or altering the sensation either at the source of the pain, at the nociceptors, that's mostly when non-opioid analgesics works, or looking at the actual perception of the pain in your brain, which is where opioid receptors work. So we'll start the process off and we'll look at the non-opioids and we'll look at the anti-inflammatory drugs. Now, looking right down in those receptors, they are mostly stimulated as far as pain side of the house goes by a inflammatory mediator called prostaglandin. Now, how prostaglandin gets initiated is via an enzyme process mostly associated with an enzyme called cyclic oxygenase. Now, we have a series of these, but the ones that most of the pain reliefs work on is either COX-1, 2, or 3. Now, if we look at the effects of COX-1, that is your effects that are always in play. So COX-1 produces prostaglandin, and that prostaglandin is associated with making sure you can have platelet aggregation when you need to. It is heavily involved in gastric mucosal production, and it's also make sure you have enough renal perfusion as well. In the presence of inflammation, that's where COX-2 comes into play, and then we have physiological and pathological effects associated with it. So when you have inflammation, you're going to want to have an increase in renal perfusion in order to excrete a lot of the waste, an increase in vasodilation, and also the associated tissue repair. So that's physiological effects of COX-2. The pathological effects is where we get our pain sensitivity and our localized inflammation will come in, and that is where obviously, when we look at most of the pain release associated with the prostaglandin-based system, that is where the actions will actually occur. But before we get on to that, let's look at our knowledge that we just learned about the prostaglandin use, and then link it to what we know about adverse effects associated with non-steroidal anti-inflammatory use. So one of the main problems that we spoke about is prostaglandin coming from COX-1 is associated with allowing renal perfusion. And then in the presence of inflammation, we actually have increased renal perfusion. Now, so if we block that side of the house, then we're going to have a reduction in renal perfusion, and we can get nephrotoxicity. That obviously can be a big problem. Now, when we're looking at platelet aggregation, that obviously can be a good thing, and it's often a reason why some of the NSAIDs are taken. But certain enzymes are associated with the formation of thromboxane, which allows for platelet aggregation and therefore allowing things to clot. Where the other side of the COX, mostly your COX-2, actually will stop platelet aggregation and then therefore make things bleed. So depending on which side of the house the drug sits, either heavily favouring COX-1 or 2, you're going to have different bleeding problems. And the last thing associated with side effects, if we look at it, we have a close link to children's and asthma, because it causes airway restriction, and the blocking of prostaglandin won't allow for normal airway function, so we get asthma. But we do allow for leukotrienes, which is another inflammatory mediator that is more associated with chemotaxis, so the bringing of the actual leukocytes to the area, which is how we can get that increased mucoid production, as well as the instigators, if you will, for that inducing asthma, especially in the little ones. Now, when we look at the stomach itself, prostaglandin heavily encourages the production of mucus in the stomach, and it also, obviously, that helps decrease the acidic secretions into the stomach as well. So we have an increase in blood flow, reduction in secretion, and an increase in mucoid protection. So in the presence of something blocking that prostaglandin, mostly along the COX-2 side of the house, then we're going to have a reduction in mucoid production, a reduction in picking up acid secretion. Understand that's a double negative. And also itself, most NSAIDs are also acidic. So you have an increased acidity within the environment, which obviously can lead to things like peptic ulcers that NSAIDs are classic for, and that is how we get that side effect. So if we just have a closer look at the type of drugs that we can find when we're dealing with NSAIDs, we have those that are non-selective, and then those that are pseudo-selective, and then some that are extremely selective. So we'll look at the very first one, which is the most prevalent one used, which is your sacchalates. So sacchalates is a class of drug which is pretty much just represented by aspirin. So aspirin is its its brand name, but its chemical name is acetylic acid, and it is a very good drug. It's used for so many years now, and it's probably, I'd say, one of the first analgesics that was ever on the planet. Well, pharmaceutical base anyway. So it's highly available, not very expensive, and it's a very good analgesic, anti-inflammatory, pretty good antipyretic, and really good at being an antithrombolytic, to the point that sometimes people are on 100 milligrams just if they have an associated risk of heart disease. So when we look at our sacchalates, they are heavily involved in the COX-1 side of the house, causing our platelet aggregation, and not so much on the COX-2. Even though they block 2, they're heavily blocking the COX-1 side of the house. So they have that ability for platelet aggregation. It also has properties associated with an antipyretic, so it's very useful for that. But there's things that you need to be very careful of when you're dealing with aspirin itself. You've got to be careful when giving it with children or women who are pregnant up to their in their last 18 weeks of pregnancy, because aspirin can cause a rare form of encephalopathy called Ray's syndrome. So you just need to be careful, and maybe even pass that on to people when you're dealing with using aspirin as an antipyretic with children. Paracetamol is a much better choice for that. Another class of drug that is very, very closely associated with aspirin is your prantonic acid derivatives. Okay, now they are your ibuprofen and your naproxen, whether it's slow or fast relief. So naproxen obviously has a much longer half-life than ibuprofen, but these ones have a high cardiovascular risk, and they actually increase prothrombotic activity. So they favour the COX-2 side of the house. So if you are mixing ibuprofen with any other NSAID, then you have a massive increased risk of causing bleeding itself. Now, other things you've got to be very, very careful of is, whilst ibuprofen can be given with children, you should only use the syrup version. Now, chronic use of ibuprofen can obviously lead to peptic ulcers and gastric bleeds, as can the rest of them. It's just ibuprofen seems to be quite available. Now, another class of drug is where your ketorolac and your indomethacin sit in, and that whole class is your indolteric acids. So indolteric acids are highly effective, but they're very potent anti-inflammatory, and they have very potent analgesic properties. One of the big problems associated with their use is you have high incidence of side effects and adverse effects, particularly gastrointestinal bleeding. So if you're giving the drug, especially if it's oral version, you need to take it with food. Now, the thing with ketorolac is it's a very effective drug, but it's not more effective the more you give. So they found out that if you give 15 milligrams IM, it's as effective as 75 milligrams IM. So you're always better off with most drugs starting at a very, very low level at the start. Now, ketorolac can be a very useful drug post-operative, as opposed to using opioids, or even as a short-term adjunct to using opioids itself. Another drug that sits in the non-selective inhibitors is your phenamates. Now, phenamates is where your diclofenacs fit. Okay, so Voltaren is diclofenac, and that's where it sits. It's a very good pain relief associated with muscle and connective tissue. It's the type of drug that most osteoarthritis, rheumatoid arthritis will use. It has that very good penetrating power into the muscles itself. One other good thing that most people don't know about Voltaren itself is it has very little effect on the gastrointestinal drugs themselves. Okay, so they're not very ulcerative, and it doesn't have a lot of gastrointestinal effects. So it is a good alternative for people who have gastrointestinal disorders. A lot of people think because it's an NSAID that it's going to cause your gastric problems, but just because these are non-selective doesn't mean that a lot of these drugs don't favour one side to the other. Okay, and diclofenac is one of those ones that doesn't have a lot of the effects associated with the mucoid tissue. Okay, and the last one that we'll talk about is quite a rare one as far as mainstream goes, but it's more selective than the rest. To tell you the truth, we have two different types. So meloxicam is very, very, very selective, whereas peroxicam is not as selective as COX-2 inhibitors, but they both fit into the same drug group, which are called oxycams. So oxycams are examples of drugs that have an insanely long half-life. Okay, we're looking 2 days average for the half-life, and up to 10 days for the peroxicams that can stay in the system. Okay, so they're really, really, really effective at staying in the body. So if they're used so much, then obviously they have a huge risk of adverse effects. If you use them properly, just once a day, or once every 2 days, whatever the regime is, then they can be really good baseline set of drugs. Now, with having a long half-life, they obviously take a long time to kick in, so they shouldn't be used by themselves or for acute pain as well. You need to have maybe an NSAID on board, and then use these ones as more of a long-lasting. Okay, another very common drug that is not technically a non-steroidal anti-inflammatory, but it does fit into the same umbrella as a non-opioid, is obviously paracetamol. Now, paracetamol works via the hypothalamus by inhibiting the synthesis of prostaglandin up there. So when we look at the whole map of things, it doesn't have a lot of effect on COX1 or COX2, so it doesn't work directly with your actual inflammatory prostaglandin. It actually will block different prostaglandins associated with pain. So as far as an anti-inflammatory goes, it's pretty shit, despite what the studies say that were released by paracetamol themselves. It's not a very good anti-inflammatory, and it doesn't have very good antiplatelet actions, but it does work really well as an antipyretic. So it actually has this lutein properties. So it's often used in children to manage fever, which is great. Now, as far as an overall picture goes, they're not 100% sure on the absolute pharmacodynamics of paracetamol, but despite that, they still use it very, very often, okay, because it's quite a safe drug when taken correctly. Okay, so one of the big benefits about paracetamol is the fact that it is a lot safer than the rest. You don't have to take it with food. It's safer with children, it's safer with pregnancy, and it's really, really quite effective. Now, unfortunately, if you take paracetamol irresponsibly, or as far as uneducated goes, then it has a huge toxicity level to the liver. So high doses of paracetamol will affect the liver itself, and it's got to do with the depletion of a liver enzyme, okay, called glutathiones. So once you have glutathiones in the system, your liver's going to be fine. But as soon as you get too much paracetamol in there that will break that away, then you're going to end up with hepatic necrosis, and that's the problem. So there's been a lot of accidental overdoses or cry for help associated with overdosing of paracetamol. The good thing is there is an antidote, but unfortunately the antidote has to be administered within 10 to 8 hours of ingestion in order to reduce the probability of liver damage. But as long as you stay along with the max dose of 4 grams a day, then most people will not have any problems associated with paracetamol. Now, paracetamol is one of those drugs that is found over the counter and is often mixed in with other analgesics because it has a wonderful synergistic effect. Let's have a look at a few things that we should take into account when deciding to give simple analgesia. Okay, what the World Health Organization would say is level 1 analgesia. We need to assess the patient. We need to ascertain what sort of pain that they're in. So is it arthritis, is it headache, is it joint pain, whatever it is, we need to know what we're dealing with. We need to know if that pain is affecting function or if it's just more of an irritating. So do a good pain assessment. Also get a baseline set of obs, because even the most stoic person won't be able to hide a sympathetic response from quite acute pain. Look at their history, look for signs of what other medication they're on, history of bleeding, gastric irritation, liver disease, or even if they're dehydrated can be a big precursor, especially for NSAIDs. If you're dealing with females, you must have an understanding of if they're pregnant. Third trimester, aspirin is completely out of the question because of that Ray's syndrome that I spoke about. It doesn't happen to every child, but it's a risk you just don't want to take. As I mentioned, other medications, a very common one that gets mixed up is people who are on Voltaren creams for a sore knee, and then they get given ibuprofen as well. The double hit of COX2, mostly inhibitors, can really bring on a person's inability to clot, and then they can actually bleed a lot more. Okay, so you just got to be really, really careful. Obviously, our plan is that we want to relieve the pain whilst improving their function. Okay, and if they have a fever, we want to control that fever, make sure it doesn't go out of hand. Now remember, low-grade fever can be a good thing, so we don't have to remove all fevers, just the ones that are causing some form of concern. Okay, when we implement the drug, we need to monitor the fact that we gave that drug, see if it works, and make sure we keep a eye on them for adverse effects. If we're giving NSAIDs, we want to encourage the give NSAIDs with meals. Okay, paracetamol, obviously not a problem. We need to have a look to see if they have those adverse effects associated with ulceration, liver diseases, bleeding problems, things like that. If they're going away, just educate them. Okay, that's all you need to do, is just educate them on the use of that medication, and especially the use of over-the-counter medication, as a lot of these low-grade meds will be found in, your cold and flu tablets, things like that. Make sure overdose is not a huge risk. Tell them to avoid alcohol, especially if they're on paracetamol or some of the stronger non-steroidal anti-inflammatories, because it does have a big effect on the liver. Once you've given the pain relief and they've come back, you need to determine whether or not that pain relief has actually worked. Because if it hasn't, then you may need to escalate. Okay, so if their fever's getting worse, if their pain is not under control, then you may need to escalate your treatment. You can also look for effects of overdoing the clotting side of the house when you're dealing with the NSAIDs. So early signs of bleeding problems, bleeding gums, blood noses, stuff like that. Just keep an eye. There are some people out there that have profound effects associated with your non-steroidal anti-inflammatory use. Okay, so that's non-steroidal anti-inflammatories. Let's move on to opioid analgesias itself. So opioid analgesics are a high-risk medication. So when you're giving them, it's a double-check sort of thing. Obviously, you need to call the MO before you administer, that sort of stuff. So it's mostly got to do with the fact that it is a drug of addiction. This is why it's considered a high-risk medication. Now, the way opioid analgesics work, unlike your non-steroidal anti-inflammatories that work by affecting the actual signals that are sent from the inflammatory site, opioids are associated with removing the perception of pain. So there's a bunch of different receptors in the body, as we all know, and 3 of them are what's known as opioid receptors. So we have our mu receptors, which is the little u, we have our delta receptors, which is that strange looking O, and the kappa receptors, which is the K, obviously. Now these are, as I said, what are known as opioid receptors. Now you may be asking yourself, why on earth does our body need to have natural opioid-based receptors? Now the reason for that is our body will actually produce its own endogenous compounds that are endogenous opioids. Okay, now these are often called your endorphins. Okay, so endorphins are really endogenous opioids, and they're used to basically stimulate a feeling of euphoria, calm, relaxation, associated with high intensity exercise to allow the body to slow down and relax. So we have these natural receptors. So when we give opioids, all we're doing is we're taking over the effect of these endorphins. So we take over the stimulus of those receptors, and therefore we have our profound effect associated with the limbic system for our emotional response and our cortical area for the perception of pain, and overall it reduces the stimulation of pain itself. So if we look at the different receptors, we can see some common trends associated with them. Okay, so the mu receptors, analgesia, we have changes to smooth muscle tone. Okay, we have our sedation, our euphoria, and we also get some nausea and vomiting. Okay, so these are found in the brain, spinal cord, and essentially around associated plexuses, which is clusters of nerves. Okay, our delta receptors are all about decreasing the speed in which our colon moves. Okay, kappa receptors is about central and visceral nociceptors and analgesia, and also reducing how fast our bowel moves. Okay, so that's what they do, and that's where they sit. Now, when we're playing with opioids, we have to remember that they are NSAIDs. So because they're S8s, they need to be controlled. So if we're carrying them, they need to be kept on us. If they're in hospitals, they need to be locked in a safe that's locked to the door, because a lot of people out there will want to steal them because it's easy to get addicted to opioids. Now, just because you can get addicted to opioids doesn't mean you should refuse any opioid-based treatment for anyone just in the risk that they can get addicted. Okay, it actually takes a little bit of effort. I'm being sarcastic. It takes a lot of effort and abuse in order to get addicted. And there's plenty of studies out there that suggest that as long as opioids have been used appropriately, then the chances of dependency, addiction, or even increased tolerance is not as high as a lot of people think. Now, obviously looking at the receptors and the list that we can obviously have a lot of associated side effects. Now, obviously we can have the high-end coma side of the house that we look at with the use of naloxone to reverse it, but more common problems associated with opioid use is your nausea, vomiting. That's a huge one. So nausea, vomiting is a big one because of your mu receptors and the decreased movement of your entire gastrointestinal system. So it's very common to administer some form of antiemetic as well. Prochlorperazine or metoclopramide is actually a pretty good one associated with its use with opioids. Meiosis is another one that can happen. It doesn't only happen in overdoses. You can actually get localized meiosis because of the stimulation of the parasympathetic nervous system. When administering morphine, it will cause obviously your sympathetic to be turned off and the stimulation of the parasympathetic, which causes your meiosis. So a lot of people have a problem adjusting to lights, focusing on fine things like reading, that sort of thing, when they're on even tablet base. Now we can get into some major side effects, which is obviously associated with your breathing receptors. So the reason breathing becomes a problem with your narcotics is you have a depressed cough and a depressed respiratory center. So your brain will actually register rising levels of CO2 less effectively, which means your stimulus to breathe is taken away. Okay, and the more opioids you use, you can obviously get that full CNS depressive state, which takes away your ability to breathe as well. On top of that, you can also get your biliary spasms. So you can have problems associated with your liver and your biliary tract, for example. So anyone with biliary colic or gallbladder problems, morphine is not an effective drug to give, neither is other types of analgesics. But morphine is the one that will stimulate the spasms of your renal colic and your biliary colic. So colic, believe it or not, your non-steroidal anti-inflammatory like ketorolac or even indomethacin is a much better choice. Now, the one that a lot of people complain about, especially the elders associated with opioids, is obviously constipation. So it is a huge problem associated with the elderly because they already have a decreased colon transit time, and then you put an opioid on board that slows it down further. So it can be quite a debilitating problem associated with the elderly. They have an increased need for laxatives, which increases the probability of dependency of laxative and causing a profound lowering of your potassium levels as well. So just because for young, healthy people, constipation is not a very big topic doesn't mean the rest of our clientele doesn't have a considerably large problem associated with constipation. And obviously those people should be educated on high fiber diets, plenty of fluids, that sort of thing, to help reduce the amount of fluids that's lost and causing constipation. Okay, I think it's a good coverage of opioids in general, so let's just have a look at a few things associated with the actual drug itself. So morphine is a very mainstay analgesic. Okay, it's given a lot. It's given in different forms, obviously IV, IM, oral, and capsulas as well. So generally speaking, the duration of morphine is around the 2 to 4 hour marks, and you have those frequent doses, and it's quite an effective drug when controlled. Okay, it's the preferred analgesic for moderate to severe pain. So if people are in wards, things like that, morphine is a good drug to give to those sort of personnel. Now, the problem is it is category C pregnancy. Most opioids are category C. We'll talk about a couple that aren't. So anyone that's pregnant, you really have to weigh up the risks of giving your morphine. Morphine even comes these days in a controlled release, so it actually has more of a slow release which extends its life up to like the 15-hour mark as well. When we look at codeine is obviously a derivative of morphine. Its durations are similar. It's mostly found in an oral tablet. So when an analgesic is given, codeine is metabolized into morphine, and that's where we get our effects after the fact. So after first pass metabolism, we get the effects of morphine thanks to a liver enzyme. Now, there are people in the population, about 10% of people, that don't actually have the enzyme needed to break down the codeine to turn it into morphine, so they actually get no response whatsoever. But when codeine is mixed with non-opioid analgesics, it was thought for a long period of time that it had an increased effect on that person's. Recent studies have obviously shown that that isn't as they thought, so now codeine use is actually reducing quite dramatically, which is a little bit of a shame because it was one of the only ones that was actually safe for pregnancy itself. Now, fentanyl is obviously one that gets talked about a lot. Fentanyl is more of a synthetic opioid. Okay, so it has a much shorter half-life, only about 30 to 60 minutes, and the effects is immediate. And most of its effects are associated with turning off your catecholamine response as well as your perception of the pain. So it's a very, very good alternative to patients that can't take morphine. It's available in IM, IV, also in transdermal patches, which is good for 3 days. You need to be obviously careful with people taking patches off and keeping them, selling them, that sort of thing, but it's a very good alternative for the long-term use of pain relief for people that are in a lot of pain. Now, fentanyl is used often during surgical procedures as well, okay, because it's very short active, it's incredibly titratable, which means it's quite effective in acute cases and your surgeries as well. But it's also category C for pregnancy. Now, tramadol is one of those ones that just binds to the mu receptors, okay, and it also inhibits the uptake of NORAD and serotonin. So tramadol can be classified as a selective serotonin reuptake inhibitor as well. So it's not used for chronic pain, okay, at all. You do not use tramadol for chronic pain. And most of the time, most people these days don't use tramadol as well. It was a particularly popular drug, but now it's sort of falling out of fashion, if you will. And that's what happens over time. But tramadol can be found IM, IV, but its most common form given is your tablet form. It's not like the rest of the opioids, as it rarely produces euphoria, and it also has a very, very low addictive rate as well, because obviously it doesn't produce that euphoria. But it has some significant side effects. One of those ones is obviously cardiac arrest, and it's associated increasing serotonin levels can lead to serotonin syndromes, which is excessive serotonin in the central nervous system, resulting in seizures and a pretty life-threatening condition. So as you can imagine, tramadol, it's sort of going out of favour. Now, oxycodone, on the other hand, is very, very commonly used. Once it's in the system, it stays active much longer than morphine. So, especially when you're dealing with OxyContin, it has a half-life of 12 to 24 hours. Endone's about the same, for 3 to 4 hours, but OxyContin, 12 to 24 hours, which is just huge. Okay, so that's why it's a very effective pain relief OxyContin is for long term. Now, endone, like the rest of them, is your category C, and the main reason it is picked over morphine is one, it can be a tablet form, and it can even be a suppository, and it just has that much longer slow release and much longer controlled half-life. So side effects are significantly less as well. Now, pethidine, for anyone who's new to the system, I would say you'd be very lucky to see pethidine. It was extremely popular back in the day, but now it's not. It's not at all. Okay, now it's not as strong as morphine. Its duration is about 2 to 4 hours. Its biggest problem is why it's not used anymore is as it's broken down, the metabolites become extremely toxic. Okay, so that's why it's not used very often. So the metabolite is called norpethidine. Now, norpethidine is associated with stimulating the central nervous system and highly associated with causing fevers. So if you see pethidine, just remember that its metabolites are likely to cause seizures, and make sure you tell all your friends because it's not often used at all. Okay, whereas methadone is one of those ones that is almost exclusively used for treatment of dependency. It still has pain relief properties, but it's almost exclusive just for those dependencies. So it produces less of withdrawal symptoms. So people who are dependent to heroin or morphine withdrawal, they'll often get put on methadone because it's easier to come off of. So they'll be put on methadone for their pain relief, and then they'll be weaned off that methadone. Now, problem with if people are on methadone and then they take other opioids as well, so they didn't fight the full addiction, it has a huge cumulative effect that makes sedation quite probable. Its half-life is around 24 hours, so it's really good and easy to do. They even have methadone clinics that people can just go into in order to get their dose per day and just get checked on as well. They even have clinics that are long-term where people who are in withdrawal will be fully looked after as well, and often on methadone. Now obviously there's a whole bunch other types of opioids, but they're just the main ones that you'll see. So when we're deciding to do an assessment associated with using opioids, we obviously need to take a little bit more into account. So we need to do a really good pain assessment. Now if you like PQRST, that's fine. Okay, another one is your old cards, so onset, location, duration, characteristics, relieving factors, alleviating factors, time and severity. So you basically, the bottom line is you want to do a good pain assessment and you want to obtain a baseline set of observations. You definitely need a history, looking at contraindications, caution with elderly people with comorbidities, and obviously head injuries are a massive consideration. Patients need to know that opioid use, one-off opioid use, is not heavily associated with addiction. It can be a massive fear and people will stay in pain and refuse opioids because of it. So education in that front is needed. What we're planning for is we obviously want to give enough opioids to control pain relief, but we don't want to overdose them and have the side effects as well. Okay, so that's a big thing that we want to look out for. When we're administering opioids, we need to be careful. Okay, we need to make sure that we've taken into account what other pain relief or other medication they're on. We need to look at their sedation score as well. So how sedated are they? Always check the last time they had their dose and see if they need the next dose. Just because it's charted up, if someone go in there and you have a high sedation score, they may not even need the next medication. Okay, so always take it into account. Don't just give it blindly. Monitor their observation, especially respirations. Get a good respiratory assessment and look for other adverse effects. When you're administering narcotics, realize why you're doing it. You want to achieve pain relief, but there's other forms of pain relief that you can do as an adjunct to opioids as well. You always want to give opioids safely. Like I said, don't give it blindly, and patients that are on it, they're going to be euphoric, they're going to be sedated. So you need to take care of their environment as well. If they're going away with opioids, then they need to be advised on the use, overuse, misuse, and synergistic effects that it can have associated with other CNS depressants like alcohol. They need to know when to call for problems, and they need to know for slow end problems like urinary retention and constipation and how to relieve them. If they get a narcotic patch, they need to know where to dispose it as well, not just throw it away, give it to a mate, that sort of thing. If someone's on long-term pain relief associated with opioids, then you need to monitor, or you need to see if it's actually working. See if people still need the pain relief, or has it moved into a body dependency as opposed to just being associated with the therapeutic effects. Okay, that is pharmacology for analgesia done. Hope you got something out of it, and until next time, take care.